The next panel, human-centric system, redesigning healthcare for the next era. All right, here's our panel. Our moderator is Chad Wabel. Chad is a hospital CEO and healthcare executive. Chad, come on up. Our panelists, Andrew Agwanobi. We'll ask Andrew. Andrew is Executive VP of Health Affairs and CEO of Yukon Health. Matthew Bauer is President of IMA Financial Group. Right, I got that. Gene O'Brien is the CEO of Value Care Alliance. Come on up here, guys. Vincent Capesi is the President and CEO of Middlesex Health. Setu Vora is the Chief Medical Officer of the Mashantucket Pequot Tribal Nation. And William Jennings is Senior VP, Hartford Healthcare, and President of the Fairfield region. All right, guys, you now, our next panel, welcome. Enjoy. I was wondering where my friend Michael Picaro is today, but he's not here. Say two. Okay.
Great, good to be with everybody today. Healthcare is certainly a hot topic, and we want to have a great discussion with you all about what's going on in Connecticut.
Hey, party people in the back, we love you, but we want to hear our panel. So folks in the back, we love the hobnobbing, but we want to hear our panel. They're all-star cast. Thank you. They're an all-star cast. We want to hear them. Guys, go ahead.
Great.
Hello.
I'm joined by some great executives and leaders across Connecticut. Healthcare has certainly come a long way, guys, for all of us. We know healthcare is in the news quite a bit, and there's so many great things going on. Wonderful hospitals across Connecticut, wonderful associations, all of you representing, you know, all of the best of healthcare. So we're going to dive in and just start talking about some of the great things that you all are doing to redefine healthcare. Dr. Agwanobi, you've been struggling with the traffic coming here like many of us, but you're here and it's great. We'll start with you, which is great. You are doing some fantastic things. Had an innovation summit of sorts at Yukon in July, I know, and have been doing some great things around innovation and redefining healthcare. Talk about what you're doing at Yukon Health.
Well, at Yukon Health, I would say that we're leaning into AI, so we think that's really important. And if we look at something like radiology, we've deployed 6 or 7 modules across radiology, but we're also looking at different models of care, particularly for the elderly. As you know, seniors, that's becoming an increasing demographic right now. And so we have a geriatric department, so we're looking at different ways, including research, to measure frailty, get ahead of the curve in terms of treating those patients in a multidisciplinary way, including dementia and things like that.
Others of you also are dealing with all the tech solutions that are out there across healthcare. Bill, talk about Hartford Healthcare and what you're doing in that space of technology and innovation and that new app that you have.
Yeah. Thanks, Chad. Thank you all for joining me and for being here today. I first of all, the question of the last panel was asked about optimism, and I hear pessimism sometimes about healthcare, and I don't believe there's ever been a better time to be a healthcare leader than right now. Lots of headwinds, but the opportunity to seize right now, based on technologies and adding new access and creating greater affordability, are driving us to innovative solutions. And you just mentioned one of them. If you haven't ever heard of HHC 24/7, it is an AI-based, app-based primary care provider in the palm of your hand. And it is transforming access in Connecticut. When you log onto the app, there are some AI-based screening questions So by the time you get to the provider, and by the way, you could be sitting in your kitchen at 6 a.m. talking to a primary care physician that through the AI interview questions has already gotten an idea of what your history and physical is. And if you're already on Epic, they've already reviewed your chart. So you can see a provider in your kitchen, not have to go to the ER, not have to go to urgent care, not have to bother your primary care physician on a Saturday morning, and get a prescription in 10 minutes. And it's affordable. It's more affordable than an urgent care or an emergency department. So it's an example of how adding access can be more affordable, and we can pair that with innovation.
Dr. Vora, you're doing some great things at Pequot Health too, around that same space, in the clinical space for sure, and partnering around innovation with that. Talk about that.
Thank you, Chad. Thank you. It's great to be here. And, someone mentioned it's a time for optimism. And I completely agree that the system is under stress, it's broken, but it's going to change for the better because of people such as what we have assembled here. We are greatly fortunate that Connecticut is in the top 5 healthiest states in the entire US. We have options, and at Pequot, we have a unique opportunity and a challenge. We are a tribal sovereign nation with its own inherent culture and political entity, but at the same time, we are also a large employer. And I think what we are trying to do is be more engaged. We have to be more engaged in the healthcare for our community and for our employees and dependents that work and play at Foxwoods and the tribe. And in doing so, we apply some lessons learned and offer that to our other commercial book of business around self-funded employer groups. So how might we think about bringing a high-touch and a high-tech approach to solving some really challenging healthcare problems? That's what we work on.
I love it. Vin, you have a great partnership with the Mayo Clinic and doing some great work around that. Talk about what Middlesex Health's doing in that space.
Sure. Good afternoon, everyone. Well, Middlesex has been involved in a very innovative and unique partnership with the Mayo Clinic for the last 10 years. And it's given our patients access to 6,000 super specialists at the Mayo for things as simple as a second opinion on a primary care issue, or as complex as a very complicated diagnosis for cancer. And it's allowed our patients to be assured that the care they're getting in Middletown, Connecticut, is at the same level as what the Mayo Clinic would do. 99.9% of the time, the Mayo Clinic kind of opines on the care that we're giving, but there's been a few times where they've provided some changes to care plans and actually save some people's lives. And this allows people to get this access without traveling, without a cost to them. And through this partnership, we're not only providing access to specialty care, but we're also collaborating on advancing healthcare in our community with the Mayo. And what they want to do is share the knowledge that they have with high-performing health systems throughout the country, throughout the world, actually. And they have a vast amount of knowledge. They've created a platform where they've invited anyone who's developing artificial intelligence technology to work with them. They have one of the most robust databases of clinical data to be used in developing healthcare, AI and healthcare. And through that work that they're doing, they're giving us kind of a front row seat to see what technology is promising and what maybe is not so promising. And that's led to us adopting a number of very high-end advanced AI technologies in radiology and in the physician's office. And so I think we're just beginning to see really the tip of the iceberg of where this is all going to go.
Let's stay on the theme of partnerships. Gene, basically your organization is all about partnership and helping the state of Connecticut. Talk about what the Value Care Alliance is doing in the state of Connecticut to improve healthcare and redesign it for the future.
Good afternoon, everyone. Pleasure to be here. I'm Jean O'Brien. On behalf of Value Care Alliance, what we have done, as Chad had mentioned, is we have been tasked with understanding, researching, and educating total cost of care. So we have an opportunity to look at all payers, all the members, high and rising risk, chronic disease states, and report back to our health systems and providers how to actually manage those members and keep them on their wellness journey. So we have a large database of claims. We have EHR data. We're able to look at the patient longitudinally and be able to do this across the state. So we're excited where we are, and I think we have opportunities at all levels.
Bill, partnerships. You and I talked the other day about some neat things you're doing in the realm of unique partnerships at Hartford Healthcare. Talk a little bit about that.
There's a legacy in our industry where we've thought we had to do all on our own. And I maintain that legacy, that mindset is over. For the same reason that Vinny talked about his partnership with Mayo. You can be stronger with other partners. Hartford Healthcare has a variety of partnerships that 10 years ago, if somebody would have said, Amazon is getting into your industry space, we would have been terrified. But now what we do is we reach out, we call Amazon, or they call us, and we partner, and that's what we're doing in Fairfield County right now. We have a partnership with Amazon, and we have 4 offices that are One Medical offices where we are their subspecialty referral network. That's an example. Hartford Healthcare is the first and only care partner of Memorial Sloan Kettering Cancer Center, the finest cancer center in the world, which many of our local residents have been used to driving to Manhattan to visit, and now they can stay in Fairfield on the Merritt, on what used to be exit 47. I don't remember what exit it is anymore. But that's another example of a partnership, and I'll give you one more. It's a fascinating idea, and if you've never heard of the company, it's a company called OnMed, O-N-M-E-D. OnMed is an unmanned primary care pod. We have one at the airport in Hartford. And it's an interactive primary care visit where you can get a prescription out of the visit, and the history and physical take place in the pod. So the history is the easy part, right? You have a screen, you have a primary care provider on the screen. But the unique part about this innovation is that there's a stethoscope that comes down out of the ceiling, and the provider guides you on how to take your heart rhythms. And if you need to have your ears looked at or your throat looked at, an otoscope, a high-resolution camera, comes down out of the ceiling. And so a bona fide history and physical can be done for those patients where it's appropriate. Again, it's a partnership. It's not for everybody. It's wildly innovative, and it's very, very cost-effective.
My wife usually guides me on how to take care of my heart, but that's cool. The stethoscope, that's pretty cool, Bill. So Matt, let's go to you. You know, this year, 2026, is supposed to be maybe the highest prices and the most costliest year for healthcare. We'll see if that plays out or not. The cost of healthcare continues to be a burden on many employers. Everyone on this stage is an employer too, not just providers of healthcare. So I think many need to recognize that these hospitals, associations, all that, don't just provide great healthcare. They're employers, so they deal with the same issues that many deal with. So there's also great innovation in technology and foresight, because you're on the provider side. But Matt, give me a sense of what's happening on the insurance side of this and how IMA is working with employers to drive down the cost of care and to make sure that when renewals come for insurance and sponsored plans that they're not as expensive as they used to see.
Well, I want to say I'm really excited to be here, and I'm looking at this from the insurance lens. And I totally agree with what Bill said and Setu said, that the good news is there's tons of opportunity for improvement. I mean, tons of opportunity. The bad news is it takes hard work. And we've found that there's tools that are coming out on a daily basis that's helping us on the front end to help underwrite risks, to be able to build plans around employee populations, because not all employee populations, as we know, are the same. And most carriers, they're providing cookie cutter plans. And what we feel that the broker needs to take the role of really dissecting what risk do they have and build a plan around that population. That's to start. But once you build that plan, you need to continue to harness that data, analyze that data, and what we're able to do is, one, continue to customize that plan to meet the needs of the employers, and then also we're able to take that data and figure out how do we help educate that population better. One of the things that we know is that there's a huge lack of employee literacy in healthcare today. And we all need to make a concerted effort to help the consumers navigate healthcare, use it properly, use it responsibly. And the better job that we do, we're going to be able to control these costs. You know, we stand in front of employers and employees on a daily basis, and most people, they just throw up their hands. You know, they say, hey, this is just a maze, I can't figure it out. And they either don't pay a claim and it's going to go to collections, or they pay it and maybe they shouldn't be paying it, right? So there's that piece of it. And then Vin and I were talking earlier, there's a lot of technologies from a preventive space that we need to take advantage of and get after some of these potential illnesses early, because we know that the quicker that we can get somebody into care for some of these serious illnesses, the outcomes are going to be better and the costs are going to be significantly less. So from my perspective, we need to double down on technology, take advantage of it, and also double down on education and let people know that the end user of insurance, they need to treat it like it's their own, right? There is an adage that I heard at a conference where they said most people treat insurance like a used car, and no one washes a used car, right? Or excuse me, a rental car. And we need people to treat insurance like it's their own. And the better that they can do that, they're going to make wise choices, they're going to be healthier, they're going to have more time on their hands, and they're going to have more money in their pocket.
And healthcare across America has risen at about 7% a year. And, you know, the ACA, which President Obama signed in 2010, you know, was supposed to bend the cost curve. And I think in some respects we've seen that, but in other respects we haven't. So what are some of the policies and what is the thinking up here around what we need to do to continue to bend the cost curve in healthcare? Andy, you want to take that one?
Yeah, I mean, I think, you know, to bend the cost curve, we have to do a number of things. One is prevention, right? And it's prevention at the care model level. So you think about care in the home, for example. You know, even if things like hospital at home haven't really taken off as much as we thought, they've proven that you can do x-rays at home, you can do infusions at home, you can do acute care at home, and things are moving in that direction even more than they have in the past. So there are models like that, chronic care models, etc. But I think also using technology, because we have workforce problems, and they're only going to get worse as we go into the future. And so yes, we have to look at more mid-levels, etc. But we also have to look at, you know, things like remote care, digital for, you know, primary care, digital first primary care. I think that's some of what you're talking about. So we have to look at the workforce. We have to look at prevention. Prevention is also at the patient level. And I'm a big fan, and I know this is sort of small at this point, but I'm a big fan of root cause types of medicine, you know, so food is medicine, functional medicine, and I think, you know, that's becoming big, and I think it's going to become integrated into our care as we go forward. And then, of course, we have to adequately fund government insurance, so things like Medicaid, etc., because of, you know, the cost shifting that we have in the system where, you know, payers often cost shift to providers, providers cost shift between Medicaid and commercial, and so on and so forth. And I think as we talk about partnerships, it's not just business partnerships, it's partnerships between payers and providers, real partnerships. Because I think when you think about things like AI and technology, right, a lot of that's going to be used in silos, which is not good. So for example, you're going to have payers looking at AI for utilization management and pre-auth and all the rest. Then you're going to have providers looking at AI for denials management and things like that. But we really need to come together and say, how can we, there's a lot of money in the system. How can we manage that money better and everybody wins at the end of the day? And I think it's going to be necessary because there's a lot happening.
Andy, I'm going to riff on one of the things you said. And when you talked about the underfunding of public payment systems, that is an opportunity we have in Connecticut. Underfunded Medicaid is one of the single largest costs to the healthcare system in this state. And until we get the courage to start funding Medicaid at an appropriate rate and equal to that of other states around our region, it's going to be very difficult. There is a misconception, whether it's accidental or deliberate, that underfunding Medicaid is not a cost. And it is a cost that's just transferred to everybody in this room.
Vin, what do you have to say about that?
Well, I think a lot has been written about the social determinants of health, and if we're really going to be serious about improving health, which will reduce overall costs of care, that's where we need to start. And if you look at this, the culture in our country has been for years, eat what you want, drink what you want, and we'll figure out the pill or the operation to make you better. And that's a recipe for disaster, and we're paying the price of that right now. And I think the big question is, well, whose responsibility is it to tackle those social determinants of health? And in other countries, the government spends a lot of money on social issues, making sure that people have enough food to eat, making sure they have housing. We don't do that in this country. And everybody's pointing the finger at whose responsibility it is. And a lot of it is falling on the shoulders of hospitals and healthcare providers. And we can only do so much. And so I think until we get serious about addressing those root cause issues, which are 90%, 80 to 90% social issues, we're really not going to get at the root cause of what's causing the health issues of this country. I mean, obesity, as an example, is a huge issue in this country. And the GLP-1 drugs are going to help with that, but that's only, I think that's a Band-Aid in some sense. But I think there's a lot of work that needs to be done in kind of coming together, both the government and healthcare providers, to try to address those issues.
Say too, you obviously have a tribal nation that you're taking care of. Oftentimes I find it interesting because you have the ability to be a lot more innovative maybe than some others to address some of these clinical issues that Vin had just brought up. I know you're doing some work in obesity. I know you're doing some work with diabetes. Talk about some of the things that you're doing there to bend the cost curve in the Pequot tribe.
Sure. And I think it goes back to Vin's point around whose responsibility is it? And when you start looking at the healthcare outcomes as a whole, and you look at the value equation, and we all agree that, the leaders here are exemplars in quality and safety. All their hospitals have Leapfrog A. They've built the human foundation of healthcare, and they're layering on innovation on top of that excellent human foundation. Magnet Hospital, 7 or 9 hospitals with Leapfrog A. UConn leading in that as well. So again, going back to the central premise around whose responsibility is it, at the tribe we believe in more of a human-centered model, where the tribe's strategic objective number 1 is that everyone in our community will have a healthier, happier, and longer life. And how might we think about health in all policy? It starts with that central awareness and driving down the total cost of care while we improve the quality, safety, and experience.
It's interesting because I mean, let's face it, healthcare is still in many ways built around institutions versus built around people and customers. I think everybody up here is trying to get at that in different ways, right? Because of this opportunity to change the paradigm, bend the cost curve, and honestly, get people healthier and get people to take more ownership. It's interesting to me that only 1 in 10 people really know how to read their medical bill because of health literacy rates. It's interesting to me that we expect people to take the stethoscope and do their heart rate and whatever else someone's guiding them to do. But it's 1 in 10 guys, 1 in 10 people, statistics say, can actually even do that. You know, what do we need to do to continue to make the customer, the employee, the patient have ownership in their healthcare, and what are we doing to build healthcare around that? Anyone can jump in.
I'll step in real quick. I mean, I said earlier, it's the bad news is going to take hard work. And, you know, I think one of the big problems is most employers look at their insurance plan on 1-year cycles. And that's it. And it's mind-boggling that take any business, it's a top 3 expense item. They look at it on a year-by-year basis, right? And they deal with it at renewal time, and then they kind of cross their fingers and hope that they're going to get a good renewal. What other expense do businesses have that are going up on a 10, 15% annual basis that they're not working on every day to get better? And most businesses aren't. And that's where, getting back to, we need the users of healthcare, the employees, to take ownership of their plan, but they need the guidance of their employer or their broker to help educate them on how to use the plan, right? And that goes to prevention, that goes to when you have routine illnesses, and you know, you could say something as basic as not run into the emergency room, but a lot of people do, right? And there's so many other ways and more efficiently from a cost perspective, time perspective, to utilize healthcare. And then the last piece, and it gets a lot of publicity, is on the RX side, where most employers, they're just riding along, and there's tons and tons of low-hanging fruit. And I'm not advocating changing people's medications. It's just, are there alternative ways to get these medications? Are we ensuring that individuals are actually taking those medications? And that's where we need advocates, and we need people that the employees can talk to, but then also in the other direction where the plans are reaching out to them, the members, and saying, hey, did you know, or are you using this? So it's hard work, and we all need to take ownership, and we all need to step up if we want to make this work.
And Matt, to your point about ownership, all the owners, the C-suite in this room, once they realize their fiduciary role in how actively they manage their pension and 401ks, and they have the same mindset when it comes to their second most expensive line item, which is healthcare, it should not be a blank check every year. How might we get there is the challenge. It does require engagement of the ownership and the C-suite. The CFO has to be engaged. Vin and the team can attest to that. When we had that patient safety movement, about 15 plus years ago, it was hard. But once the leadership got it, that the clinical improvement and safety and quality leads to better financial outcomes, it was a no-brainer. I think we need that engagement of this group to be engaged in being real stewards of healthcare.
Yeah, I'm just struck, I got to tell you, and I was a purchaser of healthcare too for a long time, but I am struck how poorly, most business owners and CEOs buy healthcare. Whether it's delegation, whether it's this literacy issue, I think we're trying to get at all of it, but it's just not being purchased very well right now, and it's extraordinarily expensive as a result of that.
Yeah, and Chad, I think a lot of that.
Ben, you've done some great things in that space.
Well, I think a lot of it has comes back to having the data, actionable data, to decide what your plan design is going to look like, what's driving your costs. And frankly, a lot of employers don't have the data. Insurance companies really don't want them to have the data. And even if they have the data, a lot of times they don't have the right people in the room. You know, no offense to HR people, but they're not necessarily focused on the financials. And a lot of times they're just want to make sure that there's no disruption in the program that they have. And unfortunately, I think we have to disrupt a lot of the healthcare plan design that currently exists out there, because if we keep doing the same thing and expect that we're going to lower costs, it's not going to happen. And so I think getting data, understanding what's driving the costs, understanding where your members are going for their health care, and making sure that they're going to entities that are high value is important.
Say too, you have your own third-party administrator company, right, within your company. You have your own PBM. You know, what are you seeing?
I think it again comes down to being extremely engaged and focused in healthcare on the prevention side, where we start thinking about how might we prevent diseases, prevent complication, and prevent harm. So primary, secondary, and tertiary prevention. But then it comes down to, again, looking at, to Vin's point, having data. Partnering with an independent TPA allows the employer groups to have claim line level data. And then you transform data into knowledge and insights that hopefully become more actionable. You provide the members with the data around their own health plan. These are the drivers of the healthcare cost. There is so much variation in the cost for the exact same level and quality of service. You make more informed consumers to direct their own care to a higher value location. Let's face it, 5 to 30% of all healthcare spend is either fraud, waste, or abuse. Depending on where we all sit, the number could be low at 5 or as high as 25, 30%. There's a lot of opportunity to make a difference.
Yeah, I'd like to I'll just add to that, you know, and just say, I agree with all of that, and I think we talk a lot about educating patients and employers, and that's critical. But I also think that we need to engage our physician providers more as co-decision makers. We call it a UConn Health empowerment of our physicians. And the reason is physicians are often viewed, and when I say physicians, I mean the whole care team, you know, nurse practitioners, mid-levels, et cetera. They're often viewed as utilizers and, you know, variable utilizers, et cetera. But if you educate providers to the same extent you're talking about, like educating employers, educating patients, you educate them on this whole issue about cost of care, what the levers are, what it causes, et cetera, and you partner with them in decision-making around care, they know better than anybody what will be costly in the longer term, in the shorter term, versus what will save you money. And the other thing is that good care, you know, the best value care is care that has high quality, safety, access, as has been mentioned before. And again, so I believe strongly in empowering, engaging with physicians and providers in answering these questions, as opposed to looking at them as the drivers of cost or variable cost, because they're part of the solution. You know, when we're finance people or admin people, we're good, but we don't really know what's happening on the front line in terms of that care. And so
Yeah, it's so interesting because, I mean, we all know that the ones that are laying hands on patients, the providers, many on this stage, are the last ones to get paid too in that scenario. And that's just fundamentally incongruent with trying to create a consumer-driven system. It just is. Because the incentives, quite frankly, aren't aligned. And the incentive misalignment has caused a lot of this cost escalation. It's caused not being able to have physicians get trained the way that they need to train, because we ask them to see 20 patients a day and get training. And so it's hard, as Matt, you said. It is hard. And so what are we doing more to redesign around that, whether it's with physicians or care teams or others up here? What are we doing to sort of get at that?
I mentioned access. I'm going to go back to access, if I may. because you made a comment earlier, Chad, about the system being largely historically evolving around the hospital. That is broken. Access to care in this country, in this state, in this county is broken, and we've failed. We have failed as an industry. So the way we can correct that failure is by adding more access, easier access, more convenient, more accessible, and making it more affordable. That will incent the patients to go to those settings and to stop reinvesting solely in the hospital. We have to have them. Look, we have to have the hospitals. We're always going to have the hospitals. They're largely going to become large ICUs if we do our jobs right and drive care into the ambulatory setting where people can find it, get it, and not look at. If you get a referral right now for an endocrinologist and you call anywhere in this state, you're likely going to have to wait 3 months, maybe 6 months. That's a failure. And by the way, none of us on this stage would have to wait that long because we all have people. No one else has people. So we have to solve that failure, and the only way we're going to do it is by leveraging advanced practice providers, because there just aren't enough doctors to do it, but to do it in an ambulatory setting that's more affordable.
No, I was just going to add behavioral health to everything that everyone said. I think the whole patient needs to be addressed, and behavioral health is a sticky situation. People are curious about it and don't want to get involved, but I think make sure that get them on their wellness journey. That needs to be brought in and needs to be talked about, and how do we look at the data in a behavioral health setting, which is very difficult for some people to understand and embrace. So I want to add that to the discussion and what everyone else had aligned with.
I just read 10% of all inpatient admissions have either primary or secondary psychiatric diagnosis in this country. 10% is what I read. Now, I got to think, like Bill was just mentioning to me, it's higher. I thought it would be higher. But that's a lot still, if you think about it. And yet we know up here our infrastructure for behavioral health. We all know what that is. It is, to Bill's point, that's another area, I think, of definite failure, not just in this state, but in many states across the country. You know, what are we doing in that space? That's a good topic here for us to talk about. What are we doing in that space to get care in the community more around that? There's a lot of integration with primary care that's happening. There's a lot of app-based work that's happening. What's happening in that space, and who wants to comment on that?
Yeah, at the Tribal Nation, we're looking at leveraging tribal sovereignty to allow trained individuals to work at top of the license, because we have a shortage. How might we start using more community-based peer coaches? How might we use the model of community health workers, community health behavior workers, who can be part of the fabric of the community or a patient population? You can imagine a large enterprise such as General Dynamics or Pfizer or Foxwoods or Mohegan or other large industry here. How might we have champions within your fabric that can enhance engagement? They can enhance awareness around resources offered by the health plans. They can connect people to the right care. They don't need to be the subject matter experts, but they can become the front line of care engagement, and they are trusted because they are part of the fabric. So we look at that as an option.
Yeah, I think the comment of access and getting somebody in front of a professional is difficult, but we can utilize technology to do that, right? Telemedicine, there's now chatbots out there that there's statistics out there, individuals that are 28 years and younger are much apt to talk to somebody via chatbot than they are someone face-to-face. So we need to provide individuals an on-ramp to get professional help. And most people, they throw up their hands, they don't know what to do. And that's getting back to, it's hard work, we need to help people navigate the system.
Yeah, and the only thing I would add to everything that's been said is we also need to integrate primary care with behavioral health. And that's something we do in our clinics, in many of our clinics. And that's important because you have to catch people where they are. You don't wait for them to need to be admitted. Someone that needs to go to the emergency department or be admitted is in a pretty bad shape from a behavioral health standpoint. And the other thing I would say is that we shouldn't neglect the fact that many of our employees need mental health help. It's a lot of anxiety, it's a lot of depression. So that's something we also, through our EAP, we actually, and our psychiatry department, we offer our employees counseling, and people take it. Quite a few people take us up on it. So it's something, you know, we always think, when we think of mental health, we always think of the terrible cases that are, you know, treated in the hospital, but everybody is subject to potential anxiety, depression, etc., and it's important to take care of that.
Well, I gotta say, you know, over 50% of someone with congestive heart failure has anxiety or depression, right? I mean, I can go down through the diagnosis, pneumonia, we could just talk about them all. But the fact of the matter is we still have a lot of room for improvement there, because a lot of the care is still not designed to say, hey, when you go to your cardiologist, is that person there to deal with your behavioral health issues? I mean, when your visit is scheduled, are they there? I mean, is that really well coordinated? And I think there's an opportunity to redesign more around that for sure. Let's change gears a little bit. One thing that you think in the system that we need to do better in the future here in Connecticut as we redesign healthcare, as you think about redesigning healthcare in the future? Bill, you want to start the show on that?
Chad, I think I've already said my one thing, and it would be a policy issue. And my policy issue would be to everybody in the state and everybody in this room, whether you're in elected office or not, and that is to focus attention on the Medicaid system in this state. It's broken, it's underfunded, and until that's solved, we're going to continue to struggle with the cost shift that is going to continue to burden the hospitals and not appropriately place the resources where Vinny said they should be, and that is in some of the social determinants of health.
Well, it's one of the only unmanaged Medicaid systems in the country, and I've heard that we were last, and now we're second to last in terms of worst in the country, behind our state, West Virginia.
I would add, if I had to choose one thing, would be that while I'm bullish on technology and AI, I think in Connecticut we need to really reinvest heavily in the human talent, in recruiting and retaining human talent. That's the foundational piece for healthcare delivery in Connecticut.
I would agree with that. Healthcare is very much a people business, people taking care of people. And as much as we talk about artificial intelligence and robots, people will never be replaced, at least in my opinion. I think that AI will be a tool, will continue to be a tool, but we need to reinvest in people, and we train a lot of people in this state. We have lots of fine health educational institutions, but a lot of the people that get trained here don't stay in Connecticut, so we have to do a better job of keeping them here.
So my wish would be everyone in the state understands and signs up for a primary care physician. I think there should be billboards on 95 and 84. Who is your primary care physician? They're the quarterback of your care, and you need to get under them, with them, stay by them to help you through the process on your wellness journey. That would be my wish.
Can we get two more in here and then we're good?
Absolutely.
Yeah,
Yes.
I think I would agree with everyone. I think that primary care is being able to retain more primary care physicians and mid-levels in the state. You know, these are, I think the formula is pretty simple. We underpay primary care providers in general in the nation. If you paid them adequately, there would be more of them. So I think looking at that is important. And by the way, I do want to put a plug in for AI, because I do believe that it will revolutionize healthcare and that we should adopt it quickly in Connecticut.
If you haven't known, but both my parents were educators, so I'm going to go with education. And it's education not only from the employer level of educating them on how to buy insurance, but also on the employee level on how to utilize insurance. So it's multifaceted.
Thank you all very much for being here today. It's been a great discussion. I appreciate all of you, and
Give it up. Thank you, Chad, Andrew. Thank you, Matthew. Thank you, Gene, Vince, C2, William. Thank you, panelists. We really appreciate it. I have a million questions for you guys too. We're going to the next panel. As the son of a hospital administrator and surgeon, I have a million questions for you too. Thank you, panel.